absent. Commissioner Shannon. And Commissioner Sirota. And Commissioner Estrada. I think she may have some audio problems. Okay.
Problems, votes, you can also vote this and approve on the chat. We'll see it as well as public. So it's approved. Anybody from the Neighborhood Councils present for public comment? So anybody from the Neighborhood Councils? Let's go to the on Zoom for public comment. Who's in the queue? Could
Thank you, Speaker. That was 2 minutes. We are now welcoming our next guest.
We appreciate you coming. We wish you a happy new year. We ask you to hang up your phone. You're welcome to listen to the rest of the meeting. Next speaker.
Next speaker is call number 024. Speaker now with the Los Angeles City Health Commission. Call number extension 024. Please press *6 to remove yourself as the winner and agenda item you're speaking on. Call number 024. Please press *6 to remove yourself and state your name and agenda item you're speaking on.
Yes, we're
It is 2 minutes per public comment on agenda item. For public comment and on agenda items, it would be a total of 5 minutes. It would be 5 minutes total. You will not proceed.
The speaker's not addressing either of the agenda items, and he's putting out a public comment.
I'm addressing the COVID issue and the budget is fucking out for stopping the happening. It's a bad civil operation. Shut the fuck up. Also, we don't have any programs for COVID in the federal government of the state of California. We the people recognize that there is and always has been a shortage of sustainable housing. That's because Eric got up and said discriminate mothers, workers, and the fucking churches like you are interrupted me. Shut the fuck up. In addition to California housing programs, I'm implementing the new law. 42 mentioned 83. Fuck you, everyone. Fuck you, everyone, too. Fuck you, everyone, and whatever the fucking hell you have for 3 fucking minutes, you stupid motherfucker, don't interrupt me. Anyhow, I hope your family enjoys cold one for the rest of their life, you piece of shit. Well, regarding renting and the purpose of renting, stop the harassment. Stop insulting California for a fucking criminal.
Mr. President, are on the agenda, so we can topic again. Thank you very much for presenting. Next speaker. Can we have a third person in the queue, please?
Yes. Admitting call-in user 1. Good evening, speaker. You are on the line with the Los Angeles City Health Commission. Caller with extension 1. Please press star 6 to unmute yourself and state your name and the agenda item you are speaking on.
The
increase due to the deficit over $700 million. How do you plan to designate this problem of rescue, abusive, money, corruption? Do you plan to have Joe Biden fix the problem that they've done? The bill is created by selfish people who send to committees, send permission for help, who realize reason, steal money from the public. People sign developers. In addition to that, the Federal President takes measures, disavows of black people, and allows some measures incarcerated and do the time for the crime. So, imagine protest of all hours that you discriminate upon those who have impacts or those who have negative declaration upon. And you have to see teachers and school workers when they go back to work soon, because the issue of children's health and welfare has been totally objectable to the lack of understanding as to what Mr. and your people are going to push him to open. And besides, Johnny Bucket is a piece of fucking shit. Johnny Bucket from Long Beach, CB15, you're a piece of shit. You fucking grand slam motherfucker. Jeez.
Thank you for your comment. The next speaker is just a fourth in the queue.
Yes, there is a fourth. We will let him in right now.
Please. Have them state their name, please.
Good evening, Speaker. You are on the line with the Los Angeles City Health Commission. Caller with extension 2. Please press star 6 to unmute yourself and state your name and the agenda item you are speaking on.
Wayne, you have your time. Wayne, you're abusing the brown. Next comment, please.
Speaker, you are on the line with the Los Angeles City Health Commission, calling with extension number 425. Please press star 6 to unmute yourself and state your name and the agenda item you're speaking on. Call with extension number 425. Please unmute yourself and state your name and the agenda item you wish to speak on. Call extension number 425 non-responsive. There will be any public comment. That was our last speaker. President Brown will now proceed to the first agenda item.
Thank you very much. The only thing, just before we go to agenda item number 1, if I can ask the city attorney if we could research whether the public breaks the rules and the law by making believe there's someone else, if that's a violation of the Brown Act, between now and the next meeting, so we can't have people abuse the right of the public to be heard. We have a rule in the number of minutes, and it's abusive to other people who are listening out in cyberspace and or our presenters. So if we can look into that between now and the next, I'd appreciate that. And for the public, we welcome public comment. We allow you your First Amendment right to be heard. However, there are rules that need to be followed for civil society ability to function. And if someone is violating that or abusing that, the full extent of the law will be utilized.
I will look, Mr. President, I'll look into that issue with regards to the current, under the governor's current emergency order regarding the Brown Act, and see if there is any guidance that we can offer for our next meeting.
Thank you very much. Moving on to agenda item number 1, we're honored to have with us. We're honored to have with us Mrna, who's the executive director, and Mrna Hernandez from the Visual Compromise. And I apologize if I mispronounced but we're honored that you can join us this evening, and I welcome you to share the screen and start your presentation.
Thank you very much. Thank you for inviting us, Dr. Mandela and commissioners. And I just wish I was there so I could give you all a big hug after that tirade. My heart hurts at the moment just listening to it, and I'm so sorry that you have to, and I hope this is the only time you've heard it, but no one should treat anyone else that way. And I don't know. I think it's just a crime shame. Are you putting the PowerPoint up? Okay. I'm trying to remember what's going on, but let me get back to we just had it up a minute ago. Okay, thank you. Yeah. So this is going to be a short presentation. We're going to be, I'm going to show you about las decisiones y compromisos and the local supervisors of the promotoras in Los Angeles, and we'll give you some more specific information. For those of you who are familiar with this, and we've been around Los Angeles for a very long time, our largest office is in Los Angeles at the Endowment Building. We celebrated this year our 20th anniversary, so we did a compromiso, and the network of promotoras and community health workers has been around for 20 years, building a network across California and across the United States, from Mexico and in Guatemala. So we're a very large network of these leaders that I'll be talking about. With this, you can move forward. Just a little history, the promoter model has its roots in other countries. It's not just a Latino model that came here from Latin America. It's the local fathers in Russia, the doctors in China, and Africa, and Latin America, and in Asia, and those wonderful leaders have been around for a very long time. It wasn't until the 60s that they came to the United States in some kind of organized form. And of course, the World Health Organization has supported the idea also as a charter. So there's a long history across the world supporting community health workers, promoters, and other comunitarios. Go ahead, Lisa. So who are promoters? This picture is a good depiction of who we are. We're young, we're older, we're men, we're women, we're Afro-Latino, we're Peruvian, and Asian Peruvian. We're a great mix of cultures from the borders. We come from different countries. We speak different languages. We're mixteco, we're indigenous, we're Mexican, we are in the United States. We translate that into being almost in every state in the United States. And so each state has turned us into kind of its own flavor. So in California, we're mostly progressive. In Texas, we're Tex-Mex. In Mississippi, we're something else. In Alaska, we fish. And we're in Hawaii. I'm hoping to go there one day and try some of those in Hawaii myself. Go ahead, Lucy. The next one. So promoters are typically, I put this up because on the left you have the promoter model, which is community model, and on the right the community focus, which is typically an institutional model. And the 60s and 70s, the 80s, they were known as community health outreach workers, the CHOWs. And in the AIDS epidemic, they became very popular and very well known as CHOWs. The community positions everywhere in between, and the titles are usually a description of funding. The categorical funding will oftentimes dictate the time and the duties for that individual and the program. Go ahead, Lisa. This is an example of one of our wonderful families who passed away about 6 months ago from cancer. And this is really what we believe in. We believe that promotores have what we call the espíritu de servicio. They're born with this heart of service. Their heart has no color. Their heart is in the African American communities, in the Jewish community, in Asian. If you think back of somebody in your family who's always helping people, who's taking food, helping neighbors, that's what we're about. That's what we call this espíritu de servicio. So what we do as a network is we build on that innate leadership, the training and leadership and advocacy. They change their families, and their families change the community. And that's what you see today. It's communities that have changed totally because they've developed programs, they share resources. And that's what we've become very famous for, is for sharing resources and being that bridge. Go ahead, Lucas. Here's some ideas about some of the things that we've been involved in. We are community members, the Servicio de Corazón, we share information, and we're involved in human rights and social justice. We're part of the socio-ecological model. We were trained by the woman on the top right, Mrna Vaccine, in liberation theology, who we really believe that in the Untitled model and in the community as being the center of leadership. Over time, we've developed what we call the community transformation model. That means that we start with a promotor in our community, we build egalitarian relationships, and at the center of that is sharing information. So that's where the training comes in. We have 13 networks across California, from Northern to Southern, Coast to Central Valley. The leaders come together and they start to share information. They're equal in these meetings. Whether they come from Mexico with a fourth-grade education like my mother, or they come from Chile with a PhD. It's one person, one voice. And that motivates them to really be active in the community because they have an equal voice and they're getting as much information as they can to share with the community. Go ahead, Lisa. The program is centered on popular education. That's really an important philosophy of ours. We teach it with our comités, we teach it to other promotores, we look at reflection, the training modules that we have, currently have about 15 curricula, and we're training at the state, the county, and the federal level. We develop curricula based on priorities that promotores have. So we have a reproductive justice curricula, we have, for instance, of course, like communities transforming. We have wonderful family friends and neighbors for informal caregivers, and we really develop curriculum centered on what the needs are in the community. And we become very popular because of the way that we teach, but also because we pay attention to what the needs are. So when we look at this health equity and social determinants, we really talk about it. We have historically talked about in-home education, employment. We have a workforce initiative where we try to promotores, we believe they're the ones who should be taking, really be employed by different agencies. Housing, healthcare, exposure to pollution, all these things are things that affect families, and that intersectionality is what we support with information and education. And now, recently, we're talking about census, COVID, and vaccination. Vaccines, and those are the issues that are most prominent right now. Unfortunately, they're superseding all of these other issues, social determinants that you see above. Go ahead, Lupin. And it's a shame because the promotor has typically interacted with everything. They've been that liaison, they've been the person who can go into the community, who can talk to people. The success of the program is so that is the content, the way that we deliver it, but it is that relationship that I can go and I can talk to somebody because I've known them. And they trust me, and we have a relationship. If I saw Dr. Mandela on the street and he remembered me, I would say hello, and we'd sit and chat for a while, right? And then we'd be able to talk about some information because now you have a connection with me. And it's as simple as that. It's finding those relationships where we can you can get information from that trusted person. And another thing. This is just who we are and what we do. And I'm going to leave this PowerPoint with you so you can look at it in more detail. But the important part is that we share similar life experiences. And I think that's really critical when we're trying to get information out to other communities. We do train in Los Angeles. We've trained about 120 African-American promotores. They love to call themselves promotores through the Best Start network, which we believe is really important, because as we start to train across cultures, then you start to build the base, a common understanding that what I want for Monza, what I want for you, is what you want for me. I want for your children. I want education, I want health, I want life, I want a job. I want all those things for your children as I want for my children. I think once across cultures we start to realize those similarities, then we start to build that base also. And so we're really interested in building the base across cultures so that we can continue to advocate for the betterment of our community. Go ahead, Lisa. Go ahead. This chart is probably the one that I hope in the PowerPoint you look at, because when we started doing census outreach with canvassing door-to-door, we really went deeper into the community, which means going to those places that nobody else knows. We have a mail that says, when you're hard to reach, you just don't know where to look for us. And that's what deeper into the community means. We did a lot of virtual classes. We went virtual on everything, just about. Our trainings are organizing, a lot of Facebook Live, and especially educational sessions about COVID, as well as wellness sessions that we moved into because of the depression and the high rate of fear for COVID. And then we just started going into communities. So we're wearing masks. We have a lot of protective gear on, and we start talking to the community about testing and, of course, social distancing and all those things. And then we're getting involved we'll be getting involved in vaccination shortly. But you'll see that one thing that we did with census, we built on that to COVID and now vaccination. And so with each plan, and we adjusted a little bit according to the community, but really their needs and how they will understand that information, answering the questions, connecting them to resources. Next one, Lisa. Lisa is our coordinator for Los Angeles. She supervises over 20 promotoras in Los Angeles alone. And she'll talk a little about some of the work that they're doing. Go ahead. Lisa is a native of Los Angeles, and she started as a volunteer promotora, as a only promotora about 15 years ago or something. And so we like to see that she's a good example of the intelligence and the commitment of our community. Go ahead, Lucas. Thank you, Matt. Can you guys hear me? I can see. I have the whole screen up and I can't really see anybody, so I'm practically talking to the PowerPoint. So please, it's great to meet you. And I think we know a couple of people on the commission already, so I'm happy to reconnect with you guys. So like what happened, my name is Lupin, and I'm a promotora from South Miami, and I got trained by one of the organizations that the community housing, and really blossomed into my love for community health work is, and really allowed to continue elevating what the promotoras do. Currently, I'm obviously a compromiso, and I coordinate these projects. I was given the opportunity to work with, under COVID, to disseminate information about COVID. The beautiful thing about it is that we had 23 promotores that had a passion and a commitment to know that they were able to provide information out in our community. Besides the fact that they had to go out to these communities that were on the high incidence of COVID exposure and then also positive tests. But they felt the responsibility, right? We also have responsibility to be part of the solution, and then also be able to share as our peers and our own members of the community talk about those precautions and those protocols regarding COVID. So we partnered with California Community Foundation, Department of Public Health, and as part of this effort, I think we were in effort with about 20 other organizations all over LA County. And together, we were able to target a couple of the different areas, communities within Los Angeles, and so we were able to provide some more direct assistance and more direct approach with our fellow community members. As you see on the map, we were able to provide more assistance in the San Fernando Valley area, which was the North Oklahoma, Sonoma City, and the Sun Valley area, and also towards the southeast of Los Angeles, which is Southgate, Cudahy, and Variance. What we did here is that we hired and we trained 23 promotores, promotores who maybe heard about COVID, but not exactly like what you could do to disinfect the PPE, the social distancing. So the promotores went to these communities and we were able to provide more information. The topics that we received as promotores to protect this outreach is that we got trained and intensive training around safety protocols. And the basic thing about hand washing, the social distancing, and then also the use of the personal protective equipment, the PPE that we call it. So these are the methods of outreach. The 23 promotores were divided into smaller groups, and we targeted different parts of the area. And the promotores that we did is that as you can see in the pictures, were very visual. So we had a lot of the in-person individual outreach. And then also in-person venue outreach. When we talk about venue, is mostly in like the food distribution areas, and then other locations where PPE was also distributed. The in-person was very, like we had mentioned, like in bus stops, people walking on the street, just anyone we were able to reach, we were giving them this information. So you see one of the promotores are going into small businesses. Because we really wanted to focus and supporting these small businesses because the larger corporation maybe has somebody already that could bring in this information. But here we wanted to support our small business owners, and we realized that there were always open doors. As you can see, one of our promotoras is hanging up a poster up in the bathroom about hand washing, other than the mobile food trucks, and then also in laundromats, and then just another location that we were able to provide information. And also, I just wanted to mention that during the weeks of November and December, it was about 7 weeks that we did this project, and we did about 4,740 outreach activities. And because of those activities, we were able to reach about close to 17,000 people. So we really hit the ground running. As you can see here, a lot of the promotoras were just making the pictures about the food distribution, people waiting in line. So our message around this is really, we don't want to use the tactic of like the fear about COVID, but how do you take care of yourself in order to take care of the most loved and precious thing that you have, which is in your home, your family. So we really wanted to provide that information to them. In addition to that, we also wanted to link them with other social service organizations because we know that there was other needs that also came about. So here, like I mentioned, we did info tables in front of establishments. We were able to partner and collaborate with the rest of the organizations. We did door-to-door, taking the protocols of the safety precautions. We only put up a door hanger, and if somebody was outside, we just let the information packet, close to their doorstep, and then we moved out of that household. And in some instances, we did phone calling as well and texting. Now, this was a massive texting. It was one-on-one texting and phone calling because we believe in making that connection with the person and making sure that if there's a need, that we can identify it and then also be able to support them. Aside from giving them, of course, information about COVID. We also use our social media platforms, which are the Facebook Live, and then also virtual presentations with maybe the school that we're still, having parent group meetings. So all of these great things, we were able to provide. So as you can see, we had a lot of great outcomes. Not because we see that the numbers were really high, but because a lot of the promoters really took the shield, like the cape, like the hero cape, out to the community, making sure that the community was well aware of what was happening, that they were able to understand about COVID, but also where to get the testing as needed. And then also we did tell them about if you do test positive, what is the next process in terms of contact tracing. So with contact tracing. So I want to make sure that people understood the process And so, we have that opportunity to do that. So we're really happy to be part of this initiative, and we continue to move forward with other projects as well regarding COVID. Thank you, Beth. I just have a few more slides, and then I'll pass my time over. So we're talking about the challenge and opportunity. The challenge is how is it that we can integrate the promoter model, the community health workers, in COVID outreach and education. But I would like to go to the first sentence that it's not just the promoter who must fit the organization, but the organization that must fit the culture values of the community. And it's really important as the health commissioner is looking at ways to integrate the promoter community health worker model. It's not an automatic, easy fit. You must really take into consideration who that person is, that individual, and their relationship to the community. The next one. And here we have just an example. The community health worker model traditionally is institutional based, more reside outside. You look at the Department of Public Health, and the department has been very successful in bringing the community health worker model. But you have hundreds of organizations across Los Angeles and in the city that have, for almost 30 years that I've been doing this work, that have promoters and have been very successful at developing that model. Look at the next one. And here's just some of the topics that we really are, promoters can be very active in. We look at health in the big H. And so, by the way, this is our annual conference that's held in Los Angeles. We didn't have one last year, we had virtual, but our last in-person one was 2 years ago. We typically host 1,000 promoters for 3 days. And I invite everybody to come to our next one. I don't know if it will be in person, I don't know where it will. It'll be in Los Angeles by the airport. 3 days where we learn, we share, we dance around, so bring your dancing shoes. And it's a wonderful place to see the world of promoters. Look at the next one. And then how do we get there? How is it that we get to really embrace the promoter and the promoter model? One is to support the integration of promoters across sectors. I mentioned the family, friends, and neighbors. We're also working out a unified school district, training parents. We are working with First Fed, also, and other agencies across the board. Wherever there's intersectionality with family, there's a potential to integrate the promoter model. And all that has to do with big health, the big H. Support community training and base building. The promoter model is at the state. I'm part of the founding board of the National Community Health Workers Association, so we're national, state, local. Support community-based organizations and provide funding for them. When the promoter model was first brought to the forefront, most everyone was a volunteer then, just like we volunteer with our church or with anyone else. But now we're professionals. Promoter who's well-trained can do almost anything. Their potential is unlimited, and their salary should be allocated towards the women for the work that they do, and supporting community-based organizations, and allowing them to engage at different levels. Next one, Lisa. And this is my contact information. I live in the Bay Area. Our offices are in LA. We have probably 20 staff and hundreds of promoters across Los Angeles. We currently employ 150 promoters across the state, which gives you an idea of the depth of the work that we do. And we work around, we're blessed enough to be able to represent nearly 5,000 promoters across the state. We work in urban areas as well as in other states and other countries. So, the hub, Los Angeles is the hub of the promoter movement. So I'm happy to answer any questions and to give any assistance if we can. Thank you.
Excellent. Lupe, could you shrink the screen so we can see everybody's face as large as we could on the... Thank you.
Stop sharing, Lupe.
Okay. That looks great. Thank you very much. First of all, Ms. Lemos and Gonzalez Hernandez, I think you guys are our heroes, and you're the ones who deserve a cake with all of applause, because you're really doing amazing work. of your model. Your model is extremely successful. It's very, very cost effective. It's very, and it's very humane. With most degrees, we can lecture to people, but they're not going to hear us. And by getting into the community and being able to articulate in a culturally sensitive manner proper health issues and proper health care, we can actually save the healthcare system. And so my question is, obviously you have a large staff, you have a lot of volunteers. It's a wonderful organization. What's your annual budget, and what's your 3 or 4 major revenue streams?
Well, I think we are right about $4 million, so I anticipate we'll double that by the end of the year. We'll probably hire to the way it's looking, maybe around 20,000, maybe 150, I suspect, across the state. And we are grant funded, but we're also a social enterprise. And so we got into that a couple of years ago when a venture capitalist came and asked to buy VCM out for $1 million. My board said no, and he came back with $2 million. And then my board said, "What are you doing?" They said, "Go run it yourself." So I went to school and we went to Variance, and this is a wonderful program. It's a social enterprise, and we went to the graduate class out of Stanford, and my staff is well informed, and it's like, one rainbow, give it away. We are so valuable. The training that we do is so important that when I went to social enterprise, and that covers the cost of the network, and for all of our trainings to the community are free. Our network trainings are free, and that's an extraordinary amount of training that Filipinos receive. And once we're on the network, everything is free. Our conference costs $40 for 3 days. That doesn't even cover a coffee for 1 day if you go to a conference at a hotel cost. So this business side, the trainings, and the contracts that we get really support the network.
Excellent, thank you. Any commissioners have questions, either raise your virtual hand or chat me in the chat box, or jump up and down, or wave your hand so I can see.
I have a question. This is Brian.
Go ahead, Brian. Commissioner Guerra.
Hi, Lupe and Maria. This is Brian Gaviria. Thank you very much for your presentation and for all the good work that you and the promoters are doing on the ground. It really makes a big impact in our communities. I want to ask you about the work, if you're doing any work on COVID-19 vaccine education, and what obstacles have you, what are people saying when you talk to the community? What are the obstacles that you're faced with? And just in general, if you could just talk about your experiences with
Well, at first it was a system. Everyone was afraid of the vaccine. I'm going to turn into somebody else, I'm going to get sicker, I need herbs. It was all this rumors that were going around. And now, because of all the publicity about lack of vaccines, now it's well known I'm not going to get it, and even if I do want it, because of the scarcity. So the main fear is not because of what's going to happen. The fear is that I'm not going to get it before it's too late, and I'm not around to get it. So our community is really on edge. I think it's very difficult. We started our first webinar on vaccines about 2 weeks ago, I think. It was with a wonderful doctor out of Ultimate, Shapiro, who was just historically so funny, and he's smart. And so we're starting with also the webinars on vaccinations. We had a testimony from 2 promoters who took the vaccine, who talked about the reactions and their fear to dispel some of the fears. So we just discussed today, we're doing a series that talks about anxiety and talks about what happens after you get a shot, and how do you develop those support systems so you could start working on emergency plans in case you're not able to get the shot. And when you do, what happens afterwards if you have a stronger reaction? So we're really going out there with messaging to dispel the myth that it's a viable option. We know there are many out there who will not take it and refuse to, but there are many who just don't have enough information to make a decision. And so we're
going out there to do that. Thank you. Appreciate it.
Commissioner Sheriff, Lorraine, do you have a question?
Commissioner Sutters, you're muted.
Okay, great. Thank you so much, Mrna and Lupe, for the wonderful presentation. I was wondering, how would one obtain your services to have the agency? My email is at lieutenantcompanymesa.org. And my phone number is on the end of your PowerPoint. It's 510-303-3444. We are happy to entertain a discussion, and we want to serve as many people. We think that we're not the only agency, we're a large one, but we also partner with other agencies across Los Angeles. We have mutual support. We have an Amigos program here with other agencies. But maybe doing some of our work. We are sharing all of our messaging, our Facebook lives, our webinars. We want to share that with everybody so that they don't have to figure out how to develop those messages. Today we have them that we just developed for the council, the Mexican Council, to distribute across all the 58 councils. And it talks about the physiology of COVID and the vaccine. And it's presented by the works for us as a physician also. In such a way that makes you just want to go and get one. It makes you, she has you listen and understand it in a way that is so extraordinary because of the way she talks with the She doesn't talk like a physician, not just the physicians, but she doesn't talk about A, B, C. She talks instead about really the heart and how this is what's happening, but this is, because this is happening, this is why you should consider having a shot. And so we're offering those free to the consul and to anybody else can buy on that we've already developed them. So contact me. We have a lot of information. We're more happy to share with anybody. It's already developed in Spanish, and we just want to get the information out there. It's too critical for somebody to get COVID and to die because they just didn't know. That's wonderful. Thank you. I was going to ask because I think somebody put on the chat about mental health, right? The messaging behind it. And I think, COVID in itself is very, you get fearful, you get anxious, you can't go out. So I think that one of the things that we also do as to get prepared is we take training about emotional intelligence. But how do we go out to the community and not only give them information, but also listen to them? We now know that there's other mental health, issues about, depression, anxiety, uncertainty about what's going to happen. So we want to equip ourselves the most that we can in order to just listen to them and then understand that if it is something that needs to be maybe attended to, we also have a component of mental health that we also collaborate with another organization. So if we can share that out when that conference or, so we have to also pass that around. But it isn't integrated into what we do because we want to take that also very, we want to pay attention to it as well. And one of the areas that we're going to start focusing on even more than we are already is our seniors, our older adults. With all of this discussion about older adults being more at risk, but not being able to get the vaccine, there's a lot of anxiety and depression that's existing in our older community, and our families don't know how to help. So we have a new mantra called, it says, let me help you help your parents. And I love that because we're going to give you information to help your parents as well as we're going to help parents deal with that anxiety that happens when they're waiting for a shot and they don't know what to do. The environment is very difficult right now, especially when they keep focusing on older adults, now 65 and older. And I'm asked to sit on the Governor's Advisory Committee on vaccines. It's so much politics that's happening with that committee. It confounds me. And what we need to do is really get as much vaccinations out. In the meantime, our older adults in particular, because they're being told they're the most at risk, already there's a lot of wellness issues that are coming up, and we're trying to develop support systems for their children, as the primary caregivers and for them.
Thank you. Commissioner Cotto, you have a question.
Yes, Maria and Lupe, thank you so much for your presentation and taking the time out. Before COVID, how much of your outreach was virtual, or was it mainly more in person? And as you're transitioning with COVID, are you reaching that population that? How are you reaching that population that might not have access to internet, but really may need, these contacts from your efforts, your group?
We were very proud that promotores have this heart of service, right? And so when they're around us, we're always embracing. I love being around promotores. We're always embracing, it's a space where you can freely say, this affection. Well, COVID cut that out totally. And so in March, we went virtual almost for everything. Since then, which were our trainings, our organizing, all those things. But since then, we've adapted to it. And so now we have special teams, like what Lupe supervises. We have teams in 5 counties right now. We're out in the community. To be visible, but also to show to the community that it's okay if you take the precautions and if you go out, and it's a way to touch our community. We've done car caravans where we go around honking, showing we've given out face masks. Some people use doing money for face masks. I put them on order for 10,000 tomorrow just to be able to distribute to the communities that don't have face masks. This is our organization that has volunteered to give us face masks. I could take an order of 10,000. Imagine. I could do 1,000 and need more. We've also done a campaign of texting, which works well. We have phone trees. And phone trees are not only for information, but it's also to take care of ourselves. How are you doing? We've been amazed the number of promotores and our staff, who have tested COVID positive and who've been ill. I don't want to tell anybody. So we develop phone trees for promotores, but for the community also. So that they can reach out and find out, I'm okay. I haven't seen you for a day. What can I do for you? Because even if we give them a piece of paper and says, here's where you can get food at the food bank, they're sick. They can't get out of their house. They don't have the energy. They don't have anybody else. So we develop these support systems. And then we're also doing we developed a channel where we're training promotores to have these support groups, the support group leaders, and they're doing these channels to bring people together virtually to talk about what's going on. My husband's home all day long, what do I do? And my children. And nobody has a job, and I don't have any food. What's happening? I don't, all those things are what is affecting our communities is causing such great depression that even if we get $30% for children, how is that going to help the anxiety that that's going to end it someday? And I don't know if my job's going to be here when all this ends, and how am I going to get through it? My children are not learning at the rate they should. There's no broadband where I live. I can't afford it anymore. The problems are exponential. So I just want to it's for all people who are at risk. And so we've developed systems that we can reach them. They know where to reach us. We may be starting a phone tree soon, a phone calling service. But the issues of accessibility are real, either because in the Central Valley we don't have broadband, or because in LA they can't afford it. And I think those are real issues. So we've just been very creative. I'm amazed at how creative people go on. I go out and I was in a car caravan in the Central Valley. Social distancing, masks, the whole thing. But they have messaging and honking. They must have reached 2,000 people just in that afternoon with messaging, giving out masks, giving out hand sanitizers, reinforcing the message that this is important. I care for them. It was a wonderful experience. It touched my heart. And it touched them to know that somebody cares about them. And I think maybe that's the most important piece. When you're isolated and you're living in South Illinois, tend to a room, living you're a home alone, or you're a mother with children and you're in love and living with you, maybe hearing that somebody cares about you It's really important, and that's what thermocollars do. They say, I care about you. How can I help you? You know, we've developed all these internal systems of care. Nobody pays us to go drop food off of people. Nobody pays us to go and help them figure out how to navigate. You know, there was one case where they opened up a food distribution center. It was for cars only. And this lady and her husband didn't have a car. So they got in, walked in there, and they didn't give them food because they were in a car. How silly is that? You know, if we could have just given it to community to disperse, then we would have gone and handed it to them. So I think part of it is breaking down the systems, you know, the only way we do stuff is not necessarily the best way. I think we have to be creative, and you have several organizations across racial and ethnic lines in LA that are ready to do this. You know, they're ready to be deployed, as you would say. You know, we have hundreds and thousands of community leaders who are ready to engage.
Thank you. And just one request. The PowerPoint that you sent, the background on some of them, it has like this tapestry with white lettering, and we can't see the letter. But the one that they pull up, you change the background so we can see it. If you could send that to Rita so she could send the one that was put up today, I'd appreciate that. Thank you.
Certainly. And I'm happy to send you some background materials, integration of the white papers that we've written. And remember, this is not just one thing that works in every community. It's something that you can integrate into the social fabric of in particular immigrant communities, but I think for everybody.
Well, your passion and compassion clearly comes through. We really appreciate that. Just a point of interest, in that exercise, I figured I would walk to the pharmacy to pick up medications for my wife, and didn't really go inside because of the high transmission of the virus. So I walked up to the drive-in area of a big chain pharmacy that was empty. No cars there, and to serve me because I wasn't in the car. Then what happens to the president of the Health Commission? Commissioner Hisworth, do you have a question?
Mm-hmm. Yes, thank you. I did have a question. Historically, there were other folks that interacted with the community, I think sometimes referred to as boroughs, who would typically be known to herbal medicines and so on. How have you interacted with folks like that? Maybe they're going away as, you know, time goes by, but I just wondered if there's still that same interaction because they had developed some rapport with their clientele, as far as I know.
So you're probably talking about Glendale.
It's called Variance, and
this is something different than Glendale.
I know, but
actually, my grandmother was a curandera. I grew up and was born and raised in San Bernardino. My parents and grandparents are from Mexico, and my grandmother was the healer in San Bernardino till she died. I was 13 when she died. And everybody was sick when we go to her, whatever it was. And so I grew up in that environment. And I think for many of the immigrant community in particular, they don't go there to fix large things, but it is an option, especially for herbal remedies. It's not going to cure some of the major things, like one of the large incidents of cancer in the Central Valley. It's not going to cure that, but it still can alleviate some of the things. So it is a thriving side business, I must tell you, and in particular for immigrants who from the home country, but Puerto Ricans had a very strong connection to it.
And do the curanderos interact with the promotores at all? I mean, you know, if you run into a community where they're there, I mean, I just wondered how the interaction might be.
I know they exist, and we do know some, but there is no direct relation. The relationship is usually holistic remedies. It's more of that than it is, you know, I can cure such and such by this remedy. We find very few of those. There are not that many. Like my grandmother.
They're going away, I guess, yeah.
Yeah, they're going away, but you have to remember the American system is so deep in our culture now that we don't have a choice any longer. There are very few options. You still have the Chinese medicine that has holistic alternatives, and then the Colombia piece, the healthy part of that would be kind of the equivalent. So some of it, the good part, I think, is moving forward.
Thank you. Thank you for your presentation and your work. Commissioner Avia.
Yes, hi Lupe and Maria. Just to make a comment, I'm a promoter of Esperanza Community Housing. Just to say, Lupe, in the 2010, I went to the school, and Lupe was one of my more strong models to be promotora, and she was my teacher in the 2010. Yes, and I'm the part of the red promotora de Visión y Compromiso, and I'm a witness of the work because I'm in the place. And just to make that comment, I'm very proud of being part of the promotora de Los Angeles, and just to say that comment. Okay, thank you. Okay.
I'm so happy to work with you, Robert, and the perspective I have. I mean, she's I'm the teacher now. Look at her, she's in the community. You have a gem here, she's wonderful.
Yeah, thank you. Thank you very much.
That's all right. I think I
Are there any other questions from any other commissioners? Seeing none, Ms. Ramos and Gonzalez Hernandez, we're honored that you come to present to us. We're so thrilled that you do what you do. You offer a vital service to the people of California and the people of Los Angeles. We're very appreciative. The Health Commission is very appreciative. The entire city is appreciative for the great work that you do. And as I think Nico was saying, I really think you want to have little cakes. You do superhuman work, and you help many more people than you can imagine. We totally appreciate what you do. Thank you for coming with us. You're welcome to stay. We have a great presentation, which is going to be, as opposed to community, it's very scientific and generic, but I've seen the presentation, and it's going to be a stellar presentation. You're welcome to join us if you like. Moving on to the second agenda item.
I think I'll go tonight, but thank you very much for the invitation. I would like to see the PowerPoint. It's a pleasure, and we're here to serve you if you have any questions. Thank you very much. Thank you, everyone.
Thank you.
Moving on to agenda item number 2, it's my pleasure to introduce Dr. Jasmine Plummer, who is the Associate Director of Applied Genomics and Computational and Translational Core at Cedars-Sinai Medical Center. Her team has recently isolated a variant of the COVID virus and has published that. And she's here to educate us about variants, strains, and in Los Angeles, one of the reasons why there's been an increase of infectivity and number of cases. Dr. Plummer, I'm honored and thrilled that you could join us today.
Hi, thank you for having me. I'm having an issue with my share button. It's no longer sharing. I don't have my slides. Is it?
Are you sure? Do you have the present now button on the bottom?
No, I'm going to present now and it won't let me. Let me try.
Maybe help out one of our tech people.
Let me check and let me chat them.
computer won't let me. Do you want to put up my slide video, or I can try to get off and get back on again? If I press all the options.
You press present now,
What?
and then you have your presentation up, correct?
And I want to, okay, let me see.
Did you select the presentation?
No, it won't let me go into show mode. And I have no idea why.
Should I co-host? Would that work?
Let me see.
I think she's jumping out and jumping back in.
Did she jump out?
I think she did, yeah.
Okay, there she is.
Dr. Pullman, you have to unmute yourself too.
Okay. Yeah. Sorry. Chrome is not happy, but here we go. Can everyone see this now?
Yes, well, thank you.
Yeah. Okay, so thank you everybody for having me. I understand the context of kind of the audience, and so I hope that we can give, thank you for inviting me. I know people have heard a lot about variants in COVID. I really did appreciate Lupe and Maria's talk, so thank you for that, because one thing I learned from myself and my team is we are desperately trying not to be alarmist, to try and give people as much information and disseminate the information in a way that's understandable and applicable, so people can really understand it and not be fearful of the crazy words or the idea of what we're finding. And so for those that this might already be unknown, I apologize, but I think it's really important to spend some time on the language. And I hope that this would help people. I really loved the organization earlier, to really understand all the scary terms, right, and be very clear about what we're talking about. So one is that we hear coronavirus tossed around, COVID-19, and SARS-CoV-2, just so that we can all start on the same page. SARS-CoV-2 is actually the virus itself. So when we talk about SARS-CoV-2, which is this fancy scientific word, we're talking about the coronavirus. To separate that from COVID-19, COVID-19 is actually the disease upon infection, right? So SARS-CoV-2 is the type of coronavirus that we're now experiencing. COVID-19 actually is that designation. It stands for coronavirus disease, which is the D, and the 19 designates that it first showed up in 2019. So that's actually the disease associated, again, with getting coronavirus and this virus that we're talking about.
I have to...
So I think that one thing I do want to clarify right now is...
Well, I want to check to see if...
I can hear people in the background. Am I still okay?
Sorry about that.
And so variant, strain, you're hearing lots of different things with UK variant and strain in South African, so I'm going to be very clear for the non-scientific on the panel. Variant is simply just a word that talks about the change at a DNA level. So everybody has variants within them where you have an A somewhere and someone else has a G, and we're still all humans and we're still okay. The same thing is going to happen in terms of a virus. A virus can evolve, and we know this from the influenza virus and many viruses, but as a virus gets passed from person to person, there are changes that happen in the DNA level. And not all of these changes equal a consequence, right? It's just a natural thing that happens, you know. Our children have different variants than we have, but they're our children and they look very much like us. So that's a variant. And then, again, all living things acquire these changes over time.
So it's very natural as viruses evolve to kind of have variants that change along from passing person to person. And so the main distinction between a variant and a strain, because you'll hear strain in the media as well, or variant, really a variant and a strain are quite similar, but the real distinction is that when a virus has so many different variants in it that behave in a distinct way, meaning, it's accumulated different variants and it makes it more infectious, or it makes it less infectious, so that would be when it's termed a strain. And so what we're going to talk about today is how to use these changes at the level of the DNA, right? We know it naturally changes as viruses acquire these variants. So they track the spread of, we can actually use that to track the spread of SARS-CoV-2, and then, really be able to start to look at how these changes, we don't need to know anything about the person. This is where it gets very interesting. So for a long time in epidemiology, so a lot of public health, we've relied a lot on public health, and it's a huge burden to really rely on people's memory, right, or their truthfulness. And I think that Maria and Lupe had touched on this. I think, a lot of people are feeling uncomfortable about saying whether or not they got COVID or where they got COVID. So relying on this kind of tracking system is also relying on people's memory, or even their truth about where they were. But if we can actually just track the virus itself, that's what we'll be talking about today. If we can just track and take everybody's samples, right, so we can actually take what virus you have in you and look and see what those variants look like. And then we can actually track people to a given area or a location using this technology called next-generation sequencing. And by next-generation sequencing, all we're doing is looking at SARS-CoV-2 and how it's changing. And what we do to do that is simply just sequence COVID-19 positive people. So these are people that had that diagnostic testing, right? All our big forums like Dodger Stadium, where we've taken swabs of them. And we just simply take those swabs and we ask the question out of every patient or person that shows up, if possible, is to look at how their SARS-CoV-2 DNA sequence looks like. And we can ask a simple question, who looks more like who? So, if person 1 and person B, A and person B look like each other, then chances are their transmission were from each other. And so this is just to give you an overall conceptual idea. What we can see is SARS-CoV-2 is quite long. So this gives you an idea of HIV versus typical influenza versus Ebola. Now what this actually shows, and we'll talk about this in terms of, the variants we see, SARS-CoV-2 is actually 30,000 base pairs. That means it has like A, C, T, G, those variant sequences of about 30,000. So it's actually quite long compared to most viruses. And that length, really this additional length, is what most of you guys have seen probably on CNN. This whole 30,000 will get packaged in a cell with all of these different types of protein to make this coronavirus. And that extra part of it is essentially this green part over here. So the green part that we're really talking about is that spike protein. And the reason that spike protein, one, makes it quite large compared to other vaccines, and the number becomes important, right? Because with the length of a genome, you have more chances of those variants happening. So, every time this gets replicated, the machinery for it to become replicated, meaning make a copy of this, you get another chance for a variant to pop up. And this spike protein that we're talking about, the reason why it becomes quite important, which is that additional length, is one, this is the protein by which we're targeting for vaccines, primarily because this little part here is what attaches to the ACE2 receptor. So that gets really kind of, people get nervous about the language, but the ACE2 receptor is actually just the place in the human cell that coronavirus can attach to and infect. So hence, this is what we are looking at and what vaccines are most targeted to. And so we did this actually a while ago. We are very lucky to be part of what happens during a pandemic is 3 oncologists, so cancer geneticists, including myself, Wenjen Zhang, and Dr. Zhao, we actually, their lab became a diagnostic lab. So that means that we were actually responsible for trying to be able to swab people and provide COVID positive or negative tests before you came into the hospital. That now includes a drive-through, so we do all outpatients, including and also the emergency room and hospitalizations. So everything we're talking about is a combination of all three. So it would include very severe patients to walk-in emergency department who did not actually get hospitalized, some that did, and also our outpatient clinics. So people will get tested prior to coming into Cedars to make sure we don't have COVID-positive patients coming into general procedures. So what I asked, and this is kind of the context, I think, for something that's really important and from an LA public health standpoint. Early in the pandemic, we asked the question, could we use this genome sequencing to actually analyze possible transmission? So at the time we looked at this, it was the end of, I think it was about the beginning of April to, end of March to middle April. And we took samples because what had happened early in the pandemic, which I'm sure people don't, early means a year ago. So around February last year, we saw actually the first case being seen in Washington State. And at that time, we'd had, I don't know if people recall, there was a cruise ship. And so we had some sprinkling of what was thought to have come from China. So China designates this kind of black arrow. So that one seeded population, so we say that population in Seattle, our hypothesis at the time, so what we thought was maybe, at this time when we took it, New York had been the center of, the epicenter of the explosion of COVID. And so what most people at the time thought and has been confirmed is that most of that had come from Europe. So these strains, so when we sequence SARS-CoV-2, we can look at, do we look more like New York, or do we look more like what was happening on the West Coast? And from this paper, we took about 3,300 genomes, and we took them primarily from the West Coast, Washington State, and New York to really see what that transmission was. How did LA actually become the next hot spot? And so what you can see here, which was actually surprising to us at the time, we had thought that probably, we had the time, this happened in February. New York had really become a hot spot in March and April, and we came a hot spot next. So by time, we thought it was actually going to be kind of this China transmission via Washington State. And this is just to give you some anchoring of trees that you may be seeing and to kind of give you context from a scientist what is all of this data. So what you can see is this was the Cedars population, all in the orange. These are the fancy trees. What do they mean? 19A just means these were kind of the isolates that were first discovered. So again, 2019 is designated. These were found in 2019. And as you can see, over time, we acquire mutations. That's quite natural. We're not saying anything about how infectious these are. These are just across the globe how we are falling into, how the Cedars population or the Los Angeles population was falling in. So again, this is a snapshot from the end of April. And what you can see is we did have some that were starting to emerge here, and most of those were from New York. So it was really interesting to look at this population because what we would have hypothesized was that we are primarily more like China or Washington State given the time that we were exposed. But the reality was the transmission was likely from New York. So there must have been some kind of travel component that was really making our rise happen in Los Angeles. And this is another fancy plot, but I think I use this to show kind of this audience is one. What's really interesting is not only can you track this globally, but what becomes most interesting, especially for the next study, is we can track it locally. So this is our 100 and I think it was 70 patients, but what you can see is kind of in this purple designation. What's pretty amazing is you have these 30,000 base pairs, but we can actually track it down to one base pair. So all of these purple designated patients actually came from one postal code. And they share exactly one base pair. They look nothing like the rest of the population and nothing like the rest of the globe. So this kind of technology allows us not to just track where do we lie in Los Angeles compared to the global population, how can we track transmission within Los Angeles or Southern California, but also even within California itself, we could actually get down to a postal code. And so how do we actually do this, and kind of what is the global effort, and how do we fit into this? This is to kind of show you how this tree is growing. And so to date now we have about 400,000 cases deposited. This is across the globe. I will say it's very biased to the UK right now because the UK has really generated a large consortium. They just deposited another 200,000 cases. But we can use this to kind of, what originally happened in our study is to really map us compared to where the other variants are. And so I'll show you this big tree. Again, this is the original strain. So again, those that disseminated or came from China. You'll remember we kind of looked somewhere along here, but our snapshot would have been around this time. And you can see this is the time component, right? So as time goes on, we're acquiring mutations. And you can see as we acquire mutations, we kind of can start to drive off into different types of global populations. So again, this is primarily still the European. We see a lot of crosstalk across the U.S. and Europe. And then this is still very much kind of more North American along here. But again, there's intermingling. And we'll talk about that next. So I use these directly from the CDC because I do want to give context to the California strain or variant that we'll be talking about. So we started this because Los Angeles, especially the Los Angeles healthcare system, had been so overwhelmed at the end of December after the holidays with our huge surge. And so we were really looking to make sure, was actually encouragement to the frontline workers, were they dealing with something else? At that time, the UK variant had been reported. And we really wanted to make sure that at least in the level of the front line, that wasn't the full reason why we were being overwhelmed. And so to give context to the group, UK variant, and you'll see these names, and so I'm just using this as an opportunity, it's really just a clade system. So the clade system you're most comfortable with from what I'm showing you now is 20B, right? So that would give you some kind of designation. So the UK strain lies right here. So it lies within this clade, and so it's called 20B. Something, the South African one, which we'll talk about next, is here. So it lies on 20H. It's also called B117. That's another just naming system. It's essentially the same thing. And for the rest of the talk, we'll talk about a UK variant versus a South African variant versus the California variant. They all change in this kind of lineage, but for the talk, we'll keep it quite simple. So why are we concerned about the UK variant? It has a mutation in the receptor binding domain, which is the spike protein. So again, everybody globally is monitoring this because we want to make sure that vaccines are still effective towards this. It was first emerged during September, and the more alarming fact was that it has come up in it has come up in a high proportion in the UK, and has now started to be seen in the United States and Canada. And now starting, I think, to emerge globally, but I took this directly off CDC. This variant is also associated with increased transmissibility, so it's thought to be more efficient and rapid transmission. However, early reports suggest no evidence that this variant has any impact on severity of disease or vaccine efficacy. So this is from the CDC, and there have been some studies to show that it is it's still efficient, that the efficacy against this variant is still okay. The other variant that we'll be talking about, which is this weird name, is the South African variant. So to give people some context, again, to where we lie, this is where the UK variant lies. Again, these are just mutations that are acquired that designates the UK versus this one you can barely see here, which is the South African strain. I'm sure you've heard a lot about the South African strain in terms of the media. The reason it's thought to independently emerge, right? So it has multiple mutations, again, in this spike protein, and we name them all out. The reason that this N501Y is important is it's also seen in the UK strain, except now the South African strain also carries these other additional mutations. So we think it's emerging independently because it does not contain this canonical. So for what we say, all the UK strains always have this deletion here. So the South African strain has the addition of this. Hence, they don't look like the South African one came off the UK one. It had this mutation, which is similar, but acquired 2 additional ones. It was first identified in October, and it was first identified in Nelson Mandela Bay in South Africa, but now it's outside South Africa, and there's some cases now reported in the U.S. But by the end of December, it seems to be the predominant variant, at least in Zambia, and currently there's no evidence to suggest this variant has any impact on disease severity. That's quite different than vaccine efficacy, right? So again, straight from the CDC, as of today, there's no evidence for disease severity, but there are starting to emerge some evidence that one of these spike mutations, so remember the UK strain does not carry this E484K, may affect neutralization of some antibodies. So where do we come in, and thank you again for being invited, is to put some context to what is home brewed right now, which is the California strain. So remembering I said that we were looking to ensure that there was no kind of issue at the front lines in terms of our huge burden at the end of December and our lack of ICUs, which everyone quite knows. And so, again, remembering that tree, I'm making it quite simple. So remember we came off kind of that China strain, so Wuhan strain is the original strain. You see these emergence. So remember, again, at that very first study, we had these clades. So we had that 20C emerging, but now if we look further in time, we have this, to give context to everybody, the strains we're talking about today, this would be the UK strain, this would be the South African strain, and this would be the strain we're talking about today. So we've designated Cal20C, and we'll talk about why it's designated Cal20C. The 20C is actually because it comes off the 20C clade, and we're predominantly seeing this strain within California itself, but most prevalent right now in Southern California. And so it, unlike these 2 strains, so you can see they're quite far apart from the UK variant, the South African variant, and you see down here Cal20C. And that's because we're defined by much different mutations. So there's a mutation not only defined in the spike protein, but also these other 2 accessory proteins, which we do not know their function right now. We know that one's a helicase and one's a protease, but we don't actually know what they are in terms of the severity or what's happening with Cal20C. We do know that there's 3 mutations or variants within the spike protein. So the Cal20C is being defined by the S131, W152, and L452R. So what does that mean in the context of kind of the larger scale of how we're looking at this both globally and I think very important for this audience locally? So what we did is when we found it within the CEDARS population, so again, remembering that these orange are our CEDARS local population, we did the exact same thing we did last time, which was to look globally. So what did we look like against the global tree? That's how I can show you that original. Here's the UK, here's the South African, and here's us. You can really see each of our patients, the majority of us, so in our case it was 36.4% way here, and so hence we termed it the Cal20C strain. And again, we collected these specifically at the end of November, the end of November to the end of December. So we really specifically collected them because we knew kind of, and it could be coincidental, but we knew the surge was accounted for probably over the holidays and gatherings over the holidays. So the next step we looked at was to look over 4,000, almost 4,500 samples that were deposited in the public data. So
not just our samples, but now that we have this defining feature of 5 mutations for Cal20C, we have that huge 400,000 public database, and we looked in 4,337 samples because we were specifically looking at the ones in Southern California and the entire state. And so this is what we can tell you. Is one, the very first time we saw it was in July, so we actually can't plot it here. So Cal20C is the red, and probably why we were invited to give a talk today. We didn't see it at all. The first time we saw it was in July. It was 1 out of 1,230. There was a sprinkling, but not even a percentage, in October. And then by the end, so over the holidays, we just saw this huge emergence. And so this emergence is actually 25% of Southern California by the end of December. It's not just the Cedars population. What I'm showing you here is 36.4% within the local population, but if we look at Southern California itself, we actually see it to start to rise to 25%, and it's continuing to rise as we speak. So context, let's get, now we know we have our own thing, so we have this Cal20C. It could be coincidental that we're seeing the emergence over the holiday that coincides with our huge, so this again, this gives context. This is the Southern California cases. So this is tracking against the California cases. So yes, while we see it rise, while we have huge cases, what I do want to point out is the proportion. So although our cases are rising, you can see that the other strains, this is rising in proportion to the other strains. So context, why do we care about variants? And again, not to be alarmist, I think that there are many reasons why we have to look at this, but also the opportunity to say that there is strength in the science. I think it is a great way to look at things without having to completely track people's behavior, because we can be agnostic, meaning we don't need information about them. All we need is their swabs. And we can link where they've been and when the larger spread has occurred. So one, we have the ability, if certain variants are more infectious, then we have the ability to spread it more quickly in people. But there is also, I think, a message here that we should take some evidence from all the other viruses to date. Just because you have more variants does not mean necessarily that you have more severe disease. And so we can say we have a very low sample right now, but we are looking into this. Does this variant actually, is it associated with milder or more severe disease? If we look at bioevolution and influenza, most of the time early in the season, people have more severe disease, but the virus itself mutates and kind of tries to evolve so that it can infect more people to survive. And hence, more people get it, but it's a milder disease. From a diagnostic perspective, so this kind of affects probably the domain of public health. The reason why that UK variant actually was seen was because it was able to evade detection by kind of our diagnostic tests. So this is where it gets a little bit problematic. If we don't have diagnostic tests that accurately can find these variants, then maybe we're COVID negative when people are actually COVID positive. I would say that a lot has evolved in the diagnostic test realm, so this is to the audience itself. For most diagnostic tests now, we use 3 pieces of the genome in order to see that you have COVID positive, and that's actually what happened in the UK. 2 of the, so there's 3 primers, 2 primers still worked, and 1 dropped out in the S protein. So the COVID test was still positive. They were able to properly diagnose, but they were looking, why was this S dropout? And that's, that could be problematic for certain variants. That's not the case for current testing for the Cal20C variant, at least when you use the 3 primer system. Decreased susceptibility, and I think this is, the name of the game right now, is is this Cal20C going to, or other variants or strains going to evade kind of the vaccines we've developed? And again, able to not just vaccines, but our own natural immunity. And what I'm here to say is we are actively looking into this. We have gleaned some kind of light into early studies, but again, we're looking at it especially concerning the California strain for variants. But this is kind of full synopsis to maybe the leader talk for what we just ended with Maria and Lupe, is what does it mean? I think not to be alarmist. I think that we need to have a very consistent message, and this is something that we've been promoting in both our media and other videos, is viruses evolve. The kind of good news about SARS-CoV-2 is that by comparison, it mutates quite slowly. So we only are seeing kind of these mutations or variants every couple of weeks. And so it is natural for viruses to evolve and spread, and not all of the variants are, I'm sure maybe a few will escape. But for the most part, we know we've spent a lot of money, especially on mRNA vaccines, to kind of get over this. So I think the vaccine message is consistent, is finding these variants is consistent with the idea of a high-scale vaccine rollout, that more people getting vaccinated will help kind of get more people vaccinated so that we don't have the virus evolve against those vaccinations. But I think most importantly for me, kind of seeing this data grow from March to now, is the messaging for especially this variant is not just wash hands, wear a mask, socially distance, stay home where possible. I think what we can say scientifically is that I could be wrong and it could be coincidental, but the social distancing, which I know is very hard, especially in a lot of low socioeconomic status households, is social distancing and stay home where possible. You know, even though we're not always able to social distancing, we probably shouldn't be going to large 50-person Thanksgiving dinners. I know after Super Bowl weekend this becomes quite problematic, and not all households can socially distance. But if we can form clusters within the households where we know, and do these 4 things consistently, I think that is kind of the altered message, is it's not just wear a mask, and it's not just socially distancing, but when you're kind of in a place of a social gathering, and I think what I think becomes convincing to everybody else is stay home where possible. If you look at kind of the transmission, when we first looked at this virus, it was within kind of our state, and now it's spreading. So, you know, is all travel deemed completely necessary? We know that, you know, it's not always possible to socially distance, especially when larger households. But we can stay home where possible, and using these 4 things together, what happened with Cal 20C is just showing us, one, that we probably, over the holidays, right, because it wasn't just normal it wasn't a normal household gathering if we allowed the numbers to explode. So the numbers are kind of coincidental with Cal 20C having the opportunity to emerge. And I think we probably likely created that opportunity with the socially distancing, meaning social gatherings at home. And restricting that will probably help us. I mean, I think for these types of studies, we can say that we can empower ourselves by doing these 4 things together and help to curb this pandemic. So I just wanted a quick acknowledgement slide, because we are, it's a lot of heavy lifting. We are cancer geneticists who are really just trying to help out in the cause, and to thank CEDARS for giving us the opportunity to do so. And I'm happy to take questions.
Fantastic. That was a wonderful, excellent overview, and taught us a lot of information in a relatively short period of time, so we totally appreciate that. If I could, I'm going to ask 2 questions. One is a very simple one for you, and the other one you might have an answer to yet. The first one is, though some of us have advanced degrees and have done research in genetics, there are people actually out in Los Angeles who are listening to this conversation that might not know the difference between RNA and DNA. So the first easy question would be, could you easily just explain the difference between RNA and DNA and the fact that COVID virus is an RNA virus? And then the second question, a little bit more complicated, is we know that unfortunately some people end up in the ICU and passing away from the disease. Has there been analysis either at CEDARS or other institutions to say that of all the different variants that are out there, that some are much more likely to put you into a ICU or unfortunately have you succumb to the disease? And then the last part of that question would be, are some of the variants more susceptible in younger people versus older people? Thank you.
Okay, so first question, DNA versus RNA. So DNA essentially is what you inherit from your mom and dad. They all compiled as A, C, T, G, 4 letters, very simple. For viruses, especially coronavirus, it's an RNA vaccine, meaning it kind of already is a little bit, has been altered from DNA into RNA, so that's one transition. But two, it uses our own host machinery to do so. So the way by which it's replicating as an RNA vaccination, as an RNA virus, is to use our own machinery. Does that clarify for you, Dr. Mendel? And then two, and that was one thing that I want to make clear from the mRNA vaccine standpoint. The Pfizer and Mrna vaccines, not to talk about vaccines, but have been targeted for these reasons, right? We did expect viruses to evolve, and so, you know, we won't get into the specifics of polyclonal versus monoclonal, but these types of vaccines have been developed with a special thought in mind of it being, one, an RNA virus, but two, it's changing over time and creating a vaccine that will adapt for that. And then the second question, which is concern of these strains within the hospital environment. So obviously the study started because of that concern, because we were in sheer numbers, really overwhelmed, especially at the CEDARS level, but we all know across LA with lack of ICU beds at the end of December. So what I can speak to is sheer numbers. When you've allowed for a lot of numbers to come in, then there are obviously going to be a portion of those people that will get hospitalized. And so that likely is the reason why we were overwhelmed. We did not see the UK strain again in our 200, and those are 200 samples pulled specifically at the time where we saw our surge. We know that it's kind of around and lurking, but that would speak to kind of your, while they're low numbers, to not be alarmist. They're not contributing necessarily. At this time, we have no data to suggest they're contributing to hospitalizations. And that's true for the very low numbers that we have for Cal-20C. Cal-20C, while it's rising, we do not see right now in the very low numbers that we have any association with increased hospitalizations. So we're currently investigating, so we have, we're working on a clinical paper now to really, what we need now is very large numbers. So when you see that 400,000, the issue with those data and kind of the power of working in a healthcare system is a lot of those data are deposited kind of from non-patients, which is great. It gives us so much information about how the virus is evolving globally. But the really nice thing that CEDARS has allowed us to do is we do get, and I think I explained early on, kind of the same idea of the drive-through patient versus the ICU patient versus the emergency department patient. So we're just kind of throwing numbers at that now to kind of really give you a proper answer, Dr. Mendel, what you just asked us in terms of, but right now in a non-alarmist way, from the small numbers we have, we don't see an association with severity.
Are there subtypes that we don't have necessarily in Southern California that are much more lethal?
So there are some suggestions. Well, none that we know are more lethal. I think that people are currently looking into that because there has been kind of a new, I mean, it's emerging every week. So people haven't really, there have been groups that are looking at variants, and again, we're relying a lot on the global set. The global set needs a deep dive into the clinical outcomes, so that, those 400,000 patients, they're not always serial collected, right? So we don't have outcome data associated with a lot of those 400,000, but I'm sure that within the next month or two, you'll probably see people looking and taking a deep dive into that data.
Excellent, thank you. Commissioner Sherman, you had a question.
So I have a quick question about the Variance. In particular,
If you can close that off.
no, I'm having trouble with it. Is that better? Okay, sorry about that. Is it the South African variant that is most likely to sort of evade the vaccine? And so, this is just a concern. I think part of it maybe fueled just by the media, but it seems like the South African variant, and maybe even the UK variant as well, there's a lot of concern that it's going to evade the vaccine or natural immunity. And I'm just wondering, as those particular variants continue to rise, what then is the susceptibility? Because I know that there may be a false sense of security for people who have the vaccine, or maybe it's made a false sense of security that they're going to be fine, and then there's this other variant out there, and then are they still susceptible to getting the other variants even if they've been vaccinated?
Okay, so let's talk about natural immunity versus vaccination, because I think those are still two separate topics. One is we don't know. So the short answer is we don't know yet. There's some data to suggest, like as you said, the South African. But from what is out there right now is all vaccinations are still, you're talking thousands of levels of difference compared to natural immunity. Right? So you've just armed yourself with thousands of levels of the ability to fight it off better than your natural immune system. So I think that would be a good message for kind of people that are nervous, right, is that you've increased your ability to fight this off. The second thing for the mRNA vaccine, and this is currently for all people, you'll see us, myself included, healthcare workers still wearing masks, is an mRNA vaccine. The Pfizer and Mrna Vaccine are it is an army ready to go, right? So we likely will not succumb to getting COVID, but we have to be exposed to it. So we want to be sure on all parts, everybody involved, even people that have been vaccinated, to still wear masks, still socially distance, still do all of those things, because when we have the vaccine rolled out issue first, right? So not everybody's going to be vaccinated, and the only way, regardless of what variant's the issue, honestly, the best way to empower ourselves is to curb it, regardless of what vaccine we're going to get, right? So, one, curb the spread, because the reality of how viruses evolve is they become more infectious to stay alive, which could be a great sign, and there'll be one strain or two strains that may kind of evade, but for the most part, I think the alarmist thing not to think about, and what I've seen for some of the vaccines, a lot of them have been cocktails. So the ones that will be able to evade are probably ones that are against monoclonal antibodies, so that's like a very specific part, whereas those are all still cocktails. They put a few together to make sure one of them will still suffice. But against natural immunity, right, vaccine versus natural immunity, we're still, please get vaccinated. If you're able, please get vaccinated, because that will actually, if your question is true, then the more people that are vaccinated, the more we will prevent variants from forming and moving on and spreading. Your question? Sorry.
Yes, it's perfect. I have a question about where we're seeing these, like in LA County or where in Southern California we're seeing the South African variant, the UK variant.
like certain areas or certain parts of the population, like grocery workers or Uber drivers or people who are on the front lines.
So that's really hard for us to say. I mean, we're exploring it. We're able to explore that because we have access to patient information. But it's very, maybe that's something generally to tell the LA Health Council. It is very difficult to track. I think the power of the genome sequencing is we don't need to know that, right? When I showed you the postal code, because we have patient information, we can answer your question, right? But the problem with a lot of the public health data, so when I showed you those 4,500 samples we looked at, that was publicly deposited. And in defense of Los Angeles public health system, a lot of that's just drive by Dodger Stadium, give your name, gender. We have no idea about outcomes because it's not serial, right? We didn't test the exact same person, came back, and so I think that's just annotation, right? Do we have the ability to properly track all the way back? In a Cedars kind of health environment, it's much easier for us to do, but I think that's a very important question that I think probably Los Angeles Public Health Department probably struggles with, but I would ask them directly. I think it's from the public health database, we literally have gender, time, if we're lucky, outcome, but that's about it. And by outcome, it's death, if it's put back in the system, but it isn't always.
Okay, thank you.
But if we roll this out I think the next stage of your question, if this was rolled out like the way the UK is doing, which is, really sequencing everybody in a very processed way, then yes. I think it's pretty convincing that I showed you I didn't know anything about the person and I knew what postal code they lived in, right? And they were at the same social gathering. And so, that was in March and it wasn't this particular study, but I think if you take your model to the next level, you would address that type of question.
Can we share the information, and is it just like the fact that you wouldn't have access to the data that public health would? Or is it someone who's not collecting any of the data, that postal code, or?
I would say that that project is doing probably a little bit of both. A little bit of both. Maybe they're actively doing it, I'm not quite sure.
Great, thank you.
So as it turned out, we accidentally brought an individual who was trying to have public comment earlier today. So we're going to go to the public now. Mr. Hector Ramirez, thank you for joining us. I apologize on behalf of the Health Commission for not allowing you to speak earlier.
Thank you. Can you hear me? Thank you. I really appreciate that. You see that this new tool from Google is actually more accessible for me than the other one, so this works out better. And I really wanted to speak on the second item in the agenda with the Cedars Sinai presentation. I am the board of directors for Disability Rights California, and currently we're engaging with our state department and governor on determining vaccine priorities and guidelines at the state level. Once he makes those determinations, he even know both county and city have the discretion of creating different priorities for vaccination rollouts. And I really wanted to recommend that this body, if not already engaged in these discussions with the Department of Health, to make recommendations based on the population of LA County that are significantly being impacted. We saw the reports today presented by the Department of Health in LA about the number of people who are getting vaccines or who have access to vaccines are not necessarily the people that are being significantly impacting and having the worst health outcomes. We see a lack of vaccine equity for the Latino, Black, and Native American communities, definitely for those individuals who are living in poverty. But as the presentation from readers from Cedars highlights, the introduction of variants as both a more urgent approach to vaccine rollout to try and get as many people vaccinated before we have more variants than the ones currently identified by Cedars. But
also to really utilize comorbidity as a judging criteria. I really wish that the depth of the analysis and the data collection that we're doing at the department would be more broad to include zip code data, like Commissioner Shannon mentioned, but also comorbidity, so that we can identify group populations that we can perhaps target with vaccines, and even with vaccine modifications, as the county or the department decides that either one vaccine might be better for one population or a mixture of others as that comes down the line, because that's definitely a viable conversation as is happening in England. And I just want us to really be ahead of the block of this great city of California, great city of LA. As somebody who has lost 4 members now to COVID, and who ran out of time for the vaccine, I see it as a significant step that this committee could do in making recommendations to the department to encourage, as Governor of New York and the department have used comorbidity as a guiding criteria. The state of New York decided that by vaccinating people who have higher comorbidities, they're actually going to vaccinate, most people who are at risk, and that was more of an equitable solution, including the age-based approach, which I am by no means discrediting, but really wanting to make it more equitable based on the people who are having the worst health outcomes. Thank you for allowing me to join you today, and thank you for this presentation, which is just so timely.
Thank you for joining us. You're welcome to keep on staying on if you like. Commissioner Hissert, do you have a question? No. Any other commissioners? Either raise your hand or chat me up or... Anybody else? I'm not seeing any. Rita, are you seeing any? Other commissioners? If not, Dr. Plummer, you're amazing. Your work is superb. Your presentation was really very informative, but also your ability to present very complex data in a way that the commission, as well as the people of Los Angeles, could truly understand it. It's really superb. You're an excellent scientist, but a really superb teacher as well, and we're really honored that you would join us today.
Thank you. Thank you for having me. And then also just a shout out to everybody here, because I know how hard it is right now for COVID, but I think the messaging is pretty consistent and pretty clear, and this is to Hector as well. I think when you have people like myself who are not COVID researchers just trying their best to help out, I think it's a big kudos to everybody involved in this commission and the other presenters here today, and also the other people that have asked questions. I think now is the time. And again, my message to everybody is we can all empower each other to do this. And I really do believe in our LA community. And it really is possible with the help of commissions like yours. So thank you again for having me.
Thank you. Why would you join us? Next business.
I just wanted to address Mr. Ramirez's point. I noted that the county health department today has put out a press release that they're going to expand vaccination access to address equity gaps. So he's very timely in his observation, and hopefully it will actually have some impact. It's not the city doing that, but the county, but when we want to control the principal vaccination group. So anyway, just happened to know what you were talking about it.
Excellent, thank you. Mm-hmm. Any other commissioners want to be heard? If not, I wish everyone a happy Valentine's Day next week. The city clerk wants to speak. Rita?
So I just wanted to share with everybody that I think I had mentioned that we have a lot of people who are retiring, and so we're doing a lot of shifting around. So I'm going to take over the duties for, keep some of mine and take over somebody else's duties, and Erica Post is now going to be staffing the commission. So, Erica, introduce yourself.
Well, just want to say hello, and you'll be seeing emails from me, and thank you. And thank you, Rita. I know she's done an excellent job keeping you guys all together here.
Megan was amazing. We're going to be very sad to have you leave the support commission. I would say that during the period of time that you have been our primary support person, that this commission has been more effective, more efficient, and we are able to get much more work done, both within the commission, but also in our advice to the city council as well as to the mayor. And on behalf of the people of Los Angeles, I want to thank you for your service to this commission, but more importantly, to the service of the city. And we know that whoever was lucky enough to steal you from us, that they're going to get the same excellent care and treatment that you've given us. We're really in your debt. We really totally appreciate everything you've done for this commission.
Thank you very much. And just know that I think that once we're able to get some more folks hired after the city recovers from this, so there's a good chance I'll be back. So we'll see how that goes.
We'll be glad to have you back. Thank you. Some other issues. Everybody can contact our interns with suggestions for presentations, ideas that you need or would like to have us addressed. And if I can have a motion for adjournment. Motion. I second the motion. Okay. Answers made a motion. Mrna has seconded. Any discussion on that? Seeing no discussion, all in favor? Anyone opposed? Let's have it. Be well, everyone. Be safe. Wash your hands. Wear a mask. Don't go out and and try to get vaccinated as soon as you can for the government. Okay.
Thank you, everybody.
So the interns are still on. The appreciates your hard work.